Good afternoon, everybody. I hope you had a good lunch and are ready for this session on spinal rehabilitation. Before we start the session, I'd like to introduce myself, Jude Meakin, and my colleague, Claire Ryan. We're both on the Executive Committee of the Society for Back Pain Research. And as this session is particularly topical to our society, we thought we'd give just a quick heads up that we're a society that's open to all members, everybody interested in back pain research, whether you're from a clinical background or from a basic science or academic background. We have some membership applications, so if anybody's interested in joining the society, please come and pick a membership application up from us at the end of this session. We have our AGM at 5 o'clock. I think it's in this room. Oh, anyway, we have our AGM at 5 o'clock today. If you'd like to join the society, we need you to return your membership application to Debbie, who'll be on the reception desk before 5 o'clock. Okay, so I'll hand over to Claire to introduce the first speaker.
Thank you. Can I invite up Natalie Gray, who's going to give us a presentation on the effect of early compared to late mobilisation following spinal cord injury on function, complications and well-being, a systematic review. Thank you.
Thank you. So I'm Natalie Gray. I am a physiotherapist and also now a PhD student. I'm based in Nottingham and also supported by the National Rehabilitation Centre. And this is the team that I work with, who are based in Nottingham Hospital and the university, and also at Loughborough University. So my study, I'm looking at the effect of early compared to late mobilisation following spinal cord injury, and this is the outcomes of a systematic review. So to start with, why have I explored this topic? Well, it is evident in my clinical work and also in the research that I've done that there's a variability in the timing of when we initiate mobilisation across the UK, and also what we do in the UK seems a little bit out of kilter with what is often happening internationally. So within the UK, some centres will start mobilisation at around 48 hours following spinal cord injury, and there's others which will take 12 weeks before we're allowed to start moving. There's various concerns in this, in that there's looking at the map, trying to get the blood pressure stable, but there's also concerns around the harms of immobilisation. So what is the optimum time? Well, that we don't really know, but it seems logical that this may well have implications for patient outcomes. And this variation is identified by a number of other organisations. So it's been picked up by NICE, it's mentioned in the Getting It Right First Time report, and it's also been identified by the James Lind Alliance, so that's come from patient feedback. And these have recommended investigation and possibly standardisation. This is my objective, to evaluate the effect of early compared to later initiation of mobilisation on function, incidence of complications and well-being in patients with spinal cord injury. So I did a systematic review following the PRISMA guidelines, and on the search, my population is adults with spinal cord injury, and I've looked at both traumatic and acquired. Mobilisation is classified as sitting upright against gravity, so that could be sitting up in bed, sitting out of bed, standing or walking. The timing of this I picked as an average in the UK, so I've gone for 4 weeks being the cut-off. So early mobilisation is those that are mobilised within 4 weeks of injury, late mobilisation where that's been commenced after 4 weeks. And the outcomes were really led on working with the PPI groups, so function, complications and well-being in particular came up very strongly on conversations with patients who've been through this. I'll also report the findings in terms of their certainty using the grade approach. So looking at the papers that I identified, so initially we started off with over 1,000 papers. These were screened. Getting down to the bottom, we found 2 papers, which was a little bit disappointing. And the reasons that these other papers were excluded, commonly there weren't comparator groups. There's actually very little documentation of mobilisation, whether it happened or it didn't happen, or if it was mentioned, it may well not have mentioned the timing of when it happened. these are the two studies that I found. One is by Scivoletto, 2005. One's by KO in 2019. Both of these are a little bit similar, actually. They're both retrospective studies, non-randomized, covering both traumatic and non-traumatic patients across all Asia grades. So they looked at medical notes retrospectively and pulled the data out from there. And these are the results. So we did manage to do a meta-analysis. It's only 2 papers, but on the element of function. Both papers used the Bartel score, and based on this, early compared to later was associated with a greater improvement in the Bartel score of 16.3 points. Complications, the earlier group resulted in a lower incidence of complications. That's 37% versus 61%, but that was only 1 paper. Neither of the papers reported well-being at all. The grade assessment, so this tells us the certainty of findings. There's a few elements here worth just highlighting to you. So the risk of bias, this is a problem in these papers because they're non-randomized designs and they were mixed quality, really looking at them. Indirectness is an issue. It's very difficult to distinguish the effect of mobilization from all elements of rehabilitation and the rehabilitation environment in this patient group. So again, that does cause us a problem. And of course, the publication bias, there's only 2 studies. So my conclusions, there's minimal literature in this field. Earlier compared to later mobilization may produce a large effect on functional gains, but the certainty in the finding is low. There isn't enough evidence to really examine the effect of timing of mobilization on complications or well-being, looking at the literature so far. So my summary is the current available evidence is not robust enough to guide clinical practice on when to initiate mobilization following spinal cord injury. And I'm happy to take any questions. Thank you.
Any questions? Maybe I can take the first opportunity then. What are your plans for your next step? I think you said you were moving on to a PhD.
So initially we were aiming for a Delphi study to try and look at some sort of consensus work, but in view of the fact that we haven't really got enough literature to even start that, I've gone down the route of a qualitative interview study, and I've been exploring the opinions around early versus late and trying to understand why people have made the decisions that they have around the timing, and I've been interviewing experts in the UK and internationally. So at the moment, I'm just starting to analyse that data, and it probably won't surprise people to see that there's quite a big difference in the opinions I'm getting internationally versus the UK. So that will be something to pull together. And then after that, I'm trying to see whether I can collect some data, which is the feedback I'm getting a lot to say we can't really move forwards until we've got literature, we've got evidence, we've got data. So how I do that, I'm not too sure yet. So if anyone's got any ideas or anyone's happy to look at any collaboration, I'd be very happy to talk to you.
Thank you.
Okay, thank you. So next up we have Leanne Wood, who's going to tell us whether pain, catastrophizing and kinesphobia, 2 big words I can't say clearly, mediate pain and physical function improvements with Pilates exercise.
Thank you very much. So I'm presenting on behalf of a team. This is an international collaboration with a team from America, Canada, Brazil, England, and Australia. And essentially, no surprise to all of you here, low back pain is a leading cause of disability worldwide. So at any one time, 577 million people are estimated to be living with back pain. And exercise is one of the most widely recommended treatments across almost all international guidance. However, how the exercise makes a change in pain and physical function and quality of life outcomes is unknown. Now, Pilates exercise is one type of exercise that might be prescribed by an exercise provider. And essentially, Pilates contains 6 different components, so centering, concentration, control, precision, flow, and breathing. And in my PhD, I'd analyzed different trials of exercise and looked at whether they specified what the exercise was trying to change. and identified a trial in Brazil which had used Pilates exercise and specified that they thought that the Pilates exercise was going to try and target pain catastrophizing and kinesiophobia in changing pain outcomes and physical function outcomes. So this led to this project, which is aimed to really try and understand whether that pain catastrophizing and kinesiophobia mediated the pathway to pain intensity and physical function. So this is a secondary causal mediation analysis of a 4-arm trial. So the Pilates trial included a booklet control arm, a once-a-week Pilates exercise intervention, a twice-a-week intervention, and 3 times a week for 6 weeks. And their primary outcomes were pain intensity and physical function at 6 weeks. Because we wanted to do a mediation analysis that was a causal inference mediation analysis, we developed a directed acyclic graph to try and identify any potential pre-treatment mediator outcome confounders. And essentially what we identified, as you can see the pink circles here, this is the DAG for physical function at 6 months. We used our mediator scores at 6 weeks and essentially identified that previous treatment, physical function at baseline, duration of low back pain at baseline randomization, medication use, kinesiophobia, mood, so were they feeling depressed or not, education level, income, gender, age, and marital status may be potential confounders. And essentially when you do a mediation analysis, if you have a look at the blue box being the intervention, so that was our Pilates exercise, and the box on the far right being our primary outcome, so pain intensity or physical function, the mediator is the bit that sits in between. And so we looked at the intervention mediator effect, so the orange line on the left, the path A, the mediator outcome effect, path B, and what we call the true natural indirect effect, which is the multiplication of those 2 paths, so the mediator path, and then the pure natural direct effect, which is the effect of the intervention on the outcome without the mediator. Using the trial data, we used only complete case analysis, which meant we had 255 participants, of which 75% were women, of an average age of 47 years and an average duration of 6.5 years of back pain. And we had 6% missing data of the mediator variables and 10% missing data of the outcome variables, which are deemed to be not important, essentially. And what we found was that on the outcome of pain intensity at 6 months, pain catastrophizing was a statistically significant mediator, and it mediated around 20% of the pathway to pain intensity, and kinesiophobia mediated around 30% of the pathway to pain intensity. However, when we go to physical function, you see that, pain catastrophizing mediated again 34% of the pathway to physical function, but kinesiophobia mediated almost 55% of the pathway to physical function. So it really comprised a larger proportion of that pathway. So what does this mean for us as clinicians? It means that we should be considering a holistic assessment when we see patients in front of us. We should be assessing whether these psychological variables are important in terms of the patient's presentation. And we may wish to use dedicated outcome measures to assess that, such as the pain catastrophizing scale, Tampa scale of kinesiophobia, to identify whether we can target our treatments to try and help patients reduce worrisome thoughts, fear of movement. And essentially this study is one randomized, it's one analysis of a randomized controlled trial, but it suggests that kinesiophobia may be a really important intermediate target in changing an outcome of physical function and pain intensity. But further understanding of how exercise exerts its effect on outcomes of importance may be necessary. So thank you very much.
Thank you. So if anybody would like any questions, please make your way to the microphone. In the meantime, so this might be a bit of a naive question, but the 2 mediators that you've looked at, do you know that they're completely independent, or can there be anything that connects the 2 of them?
Sorry?
The 2 mediators, are they independent or can they be connected?
So it's a very good question. And what we did do is we analysed whether they were correlated in terms of together or with the outcomes of importance. Their correlation was around 55%, but generally the cutoff in the literature is around 65%, so we therefore deemed that they were not strongly correlated. And arguably, if you look at the factor analysis of each of those scales, they do try and target different things. They're subtle but different. And obviously, if someone is catastrophizing, they may not always be fearful of movement, but they may have greater worries. There is definite overlap but they weren't 100% correlated at all. So we did look at it as.
Great. Thank you very much, Leanne.
And if we can invite up Helen Oakes to present Learning to Swim with Back Pain, a qualitative study of swimmers with chronic low back pain.
So I apologise for the title slide, but so my name's Helen. I'm a physio, a PhD candidate, and also a swimmer. Okay, so swimming is often advised to people with low back pain by health professionals despite limited evidence. Swimming is rarely provided as a rehab tool, and there's limited data on uptake and use of swimming in this population. Swim England have published testimonials whereby swimming has had a positive impact on health, but to date there's been no attempt to evaluate or synthesize the experiences of swimmers with health conditions to identify if there are common themes. So the aim was to explore the experience of people who use swimming to manage chronic low back pain. It was a qualitative study using semi-structured interviews, recruiting swimmers who use swimming to manage back pain, and the interviews were conducted by telephone, video conference, or in-person outdoors. Topics included experience of swimming with back pain, strokes, drills, adaptations, dose of swimming, motivation, management of setbacks, amongst other themes, and thematic analysis was used to analyse the data using a combination of a priori and through the development of inductive codes. 14 swimmers were interviewed, 4 male, 10 female, 6 were pool swimmers, 5 were outdoor, and 3 swam in both locations. 5 themes were developed, which outlined a journey from the swimmers learning to swim with low back pain, adapting their swimming stroke, developing a training regime, integrating into a community of swimmers, and incorporating swimming into daily life. The first theme, My Back Pain Journey, provided context and understanding of the swimmer's low back pain history, included 4 sub-themes. The second theme was learning to swim with back pain. There were 4 sub-themes. My swimming journey, so each swimmer shared a different story describing how they started using swimming as a management tool. Some had always swum and were competitive swimmers, some only swum occasionally for leisure, and for others, swimming was a transition from other exercise they could no longer manage. How I feel my back feels when I swim. This sub-theme was about the water providing support, stability, and a safe environment in which to exercise. The swimmers were aware of how their back felt while swimming, and they adapted their stroke and choice of stroke to reduce or eliminate uncomfortable or painful sensations. How I swim with back pain. So front crawl and backstroke were the most popular strokes. Some mentioned they'd been advised against swimming breaststroke. One swimmer avoided breaststroke as she was having a flare-up, and another would only swim it later in a session. My barriers and how I overcome them. So the less able swimmers discussed gaps in swimming ability and skills and the desire to take lessons and improve technique. They also spoke about comorbidities, how this impacted their choice of swimming stroke. Theme 3, how swimming looks for me, included where I swim. So the swimmers swam in several locations, including the pool, sea, rivers, lake. So one pool swimmer found colder water was a problem, whereas the outdoor swimmers found the cold to be beneficial. My swimming community, so some swimmers swam with clubs or informal groups, and for the outdoor swimmers, the support groups were important from a social point of view, but also for safety. My training regime, so the ex-competitive swimmers and to some degree the less able swimmers spoke about the different aspects of training they use when swimming. The swimming dose was discussed, including time in water, distance swum, and swim frequency. Theme 4 was what I gained from swimming, so 3 sub-themes. Relief through swimming, so when describing the impact of swimming on symptoms, the swimmers often used the word relief. They reported feeling more mobile, they felt their body grow after swimming. Swimming improves my physical and mental health and helps me function. They discussed how swimming helped them maintain a healthy weight, improve mental health, muscle strength, fitness, enabled them to lead a normal life. And my feelings about swimming, the words the swimmers used in the interviews conveyed their feelings about swimming: confidence, empowerment, enthusiasm, hope, and eagerness to share. The final theme, keep calm and carry on swimming, included 3 sub-themes. My goals and motivation. So some spoke about setting goals, signing up for challenges. Other sources of motivation included wanting to maintain a healthy weight. Developing a swimming habit. They developed an exercise habit. Swimming had become automatic and part of life. And the final one, developing setback plan and resilience. They had a setback plan for when they experienced a flare-up of symptoms. It was clear that swimmers had been resilient and others had developed resilience since swimming. So in conclusion, the study found swimming was a valuable and effective self-management tool. It could provide an alternative form of exercise for this population, helping people manage pain, improve mobility, mental health, and levels of physical activity. Thank you.
Thank you. And just a question from me to start. Just the implications of the work, do you think? What do you think the implications might be?
So the implications are, I think a lot of people advise swimming just at maybe the end of a consultation. You should try swimming. What it shows that swimming can be practiced in many different ways, and I think there's a lot more to that advice that we there's more advice we can provide, maybe to enable people to use swimming, particularly with the less able swimmers. I think the competitive swimmers already had quite a lot of ways of adapting their swimming. I think people might benefit from having swimming sessions provided. And if you have a look at, I've got a poster, and it's looking at a feasibility study where I've actually trialled a swimming program, and if you're interested, I think it's number 47. Thank you.
Smashing. And just one more question, I think, there. Thank you.
Hi, I'm Rajat Verma from Manchester. I was just wondering, did you do any scores like for psychological scores or ODIs before and after? Because that will make this more powerful, I think, if you do. Because these are self-selected groups. These are patients who are actually quite self-motivated. So psychologically, they're already ahead of quite a lot of patients that we see. But if you can demonstrate that their mental health scores and their disability scores have improved before and after swimming, maybe this will become a bit more powerful message.
Okay, yeah. So because it was limited time, what I didn't say is that these people were recruited via social media. They weren't accessing any healthcare. So I was interested in what people who don't need to see me, how they use swimming. And they would be determined like an expert patient, I would say.
Thank you.
Thank you.
Okay, so our fourth speaker in this session is Suzanne McElroy, who's going to talk about changing walking ability and factors associated with outcome after surgery for neurogenic claudication.
Thank you. Hello, my name is Suzanne McElroy. I'm a consultant physiotherapist at King's College Hospital and a PhD student at King's College London, and I'm funded by the Dunhill Medical Trust. I'd like to talk to you today about change in walking ability and factors associated with change in outcome after surgery for neurogenic claudication. So as you all know, neurogenic claudication is extremely common. It causes pain and walking restriction, and it's the most common cause for lumbar surgery in older people. And while surgery can be very effective, up to 40% of people report ongoing pain and walking disability post-operatively. And those that do report an improvement, very few of them seem to actually go on to increase their daily walking, and therefore they're at risk of the negative consequences of inactivity. Now, the reasons behind this persistent walking disability are likely to be multifactorial and probably include biopsychosocial measures and behavioural factors. And if these are known, then they could potentially be targeted with rehabilitation so that outcomes such as walking could be improved and quality of life improved. Therefore, I aimed to identify the modifiable factors associated with postoperative walking. I conducted a prospective longitudinal study. Participants were recruited from 3 hospital trusts. Participants all had to be over 50 years old and waiting surgery for neurogenic claudication, and if they had any other cause of primary walking restriction, they were excluded. A comprehensive battery of biopsychosocial measures were collected pre-surgery, at 6 weeks, and at 12 weeks post-operative, and I'm currently collecting some 12-month data. Measures included self-reported falls, fear of falling, fear of movement, stress, pain, all sorts of measures we collected. Then also we collected objective measures, including the 6-minute walk test, mean daily step count over 7 days using an accelerometer. We had grip strength and low limb physical performance battery. So I recruited 134 participants. Of these, 116 underwent surgery and 109 have provided follow-up data at 3 months. 51% were male with a mean age of 70 years and just over 72% were white British. So the good news is that surgery worked. All the outcomes that we see on the slide, the 6-minute walk distance, daily step count, and ODI statistically improved post-operatively. However, if you have a look at the column on the right, where we actually see the percentage of people that achieved the MCID, we see a slightly different picture there, with in fact some people with it hovering around 50%. We also saw that in some participants, their outcomes worsened, and this was particularly seen in the mean daily step count, where 39% of people were walking less at 3 months post-surgery than they had preoperatively. In addition, we saw that only 25% of the participants were walking a recommended sort of 7,000 steps a day, which is recommended for an older adult for well-being. So using linear regression adjusted for their preoperative scores, age, sex, BMI, and ethnicity, we saw that the strongest predictor of change in walking was preoperative walking ability. In addition, we found that people that had high fear of movement or high fear of falling or post-operatively or at 6 weeks, or either it remained high or it increased, they demonstrated less improvement in their walking at 12 weeks. The other variables that we collected preoperatively and at 6 weeks did not have a strong association with change in walking at 12 weeks. We therefore looked at what preoperative factors were associated with preoperative walking. And the factors on the slide all reached statistical significance at the 5% level. So we found history of falling, fear of movement, grip strength, lower limb performance, planning and monitoring exercise, support of family and friends, emotions, and the control and understanding of the condition were all associated with preoperative walking. Therefore, in summary, there were significant improvements in outcomes post-surgery. However, for many, they didn't seem to be clinically significant. In addition, only 25% of people are walking the approximate recommended 7,000 steps a day. Preoperative walking explains a large proportion of the residualized change score in walking improvement, with a number of biopsychosocial factors associated with this. Preoperative rehabilitation may be required to optimize our patients before surgery, and for those that have high fear of movement or high fear of falling post-operatively, additional support may be required. And I just want to thank my supervisors and the participating trusts. Thank you.
Thank you very much. Do we have any questions from the audience? Yeah.
Thanks, it was a very interesting talk. Did you differentiate between those candidates able to walk independently versus with an aid? And did that have a difference?
Yeah, we did look at that. And yeah, the people that used an aid were associated with less improvement. But we wonder whether that's an independent factor is something very different, because we found it was much more associated probably with their balance. So there was a differentiation there.
Does this mean there are implications for preoperative targeting of behaviour or the associated things with the dependent variable preoperatively?
Absolutely. So I actually started out thinking that maybe sort of post-operative rehabilitation was really required because I was identifying ongoing issues with these patients at their post-operative checks. And so I thought that I would probably be looking at post-operative rehab. But what I've found from my results is it's so strongly associated with the preoperative variables that I think that's probably where that we need to really sort of try and optimize our patients. And for many of us working in the NHS, the waiting lists are very long. So we do have sort of the potential to intervene and to help these patients.
Thank you, and we'll give Suzanne a hand and end the session, so I'm sorry to miss your question, but thank you.